I'm very pleased to be here. Božida is not here, but I like to congratulate him on assembling a group of very diverse speakers. All of us have very different expertise, and I think very useful in moving the field forward. I'm going to speak about a boring subject because I have spent my life in pharmaceutical medicine, and what I do for a living is to develop. You can't hear? Now you can? Okay. No. 1, 2, 3? Good. So I wanted to ask how many this moves, and when it moves, it's how many physicians do we have in the audience? No physicians. Well, that's a sad story. I think we need to get them into the room next time, and it's not for my talk. They would have benefited from all the others. What I wanted to start with, I wanted to say that most people don't know about the fact that cannabis prohibition hasn't started with the prohibition of psychoactive medicine. Cannabis prohibition started with prohibition of alcohol, because as we are talking about how useful it is, in fact, cannabis plant is one of the best sources to produce alcohol to power vehicles. And in 30s, there was a big battle as to how the cars will be powered. So, for example, Henry Ford not only had a car made largely with cellulose that wasn't just cannabis, but he also ran a whole plant in Michigan that produced a lot of byproducts from hemp, and that including the alcohol. So the issue was, will the cars, do you think that will be better? Will the cars be run on petrol versus ethanol? And as we know, they have been run on petrol because people who wanted to ban cannabis and alcohol won. And the ban for medical cannabis followed the ban on alcohol. So alcohol ban was not about drinking. It was about motor vehicles, and medicine followed. You all know that cannabis is extremely useful, and I'm not going to go through every single bullet point because others have done it for me. And what I want to tell you is that for better or worse, there are a lot of studies ongoing. So you can see that right now we have about 156 studies ongoing. And I have been doing this survey for many years. And actually, this figure has doubled. So within 4 years, we have double the amount of studies. With cannabidiol alone, we have 50 studies. And these are taken from a database in the United States where most people register the studies. So they are truly ongoing studies with cannabidiol. With THC, you have 68. And as you can see, in Europe, we're still relatively modest, but we're getting better. A few years ago, there were almost no studies in Europe. And for those of you who know what SATIFX is, take a look. They have together conducted 600 studies, and today they have 140 ongoing. That's what it takes to register that little herbal extract for a variety of indications. I will not be very detailed. I would suggest that the organizers will make it available to people who want it, because there is a lot of information, and I put the information there in order to give it to people, not to hide it. So I'm not going to make a talk lasting 2 hours, but those of you who want it, they can get it from me. My email was at the beginning. If they don't, you get it from Božida, I'm sure. But that's the objective of it, is to share it. So what I wanted to say is, if you look at multiple sclerosis, the data was not so brilliant. If you look, no improvement in the Ashworth score. The initial, this is data coming from 2003. And all the same extract. It just shows you that it's not that easy to show efficacy in clinical trials. You had just subjective differences, and you've seen something on the long term, again, small effect. If you look at the other studies, again, improvements were only seen by patients who were self-reporting. And by the way, the indication is a treatment for a relief of spasticity in patients who haven't responded to other therapies. And I think this is an overarching theme in cannabis. That's what we get. We get usually, if we do get indication, it's in refractory patients. We don't go first line because we don't do really enough work. We don't have enough evidence. And there was another study, again, a very recent study that looked at whether THC was able to slow disease progression, and it's not the case. Lots of people enrolled, almost 500, and effectively no impact other than, again, for some participants who were at the lower end of the disability scale. The, again, more recent study, this one was done with Canada, actually showed some statistically significant relief and statistically significant improvement in sleep as compared to placebo. And you will find, again, a very recent study that aimed to look at whether cannabis or cannabinoids can slow disease progression, and I'm afraid the failure, no efficacy. And I take the point that some people will argue that this is because this is a GW study and it's due to the extracts that they used, and there are better extracts, but nevertheless, this is the data for the time being. You will find some interesting data for Nabilon that shows that it's effective for neuropathic pain related to multiple sclerosis, but as in combination with gabapentin. And there is a very new study from Colorado where Dr. Bob used to be. And I'd like you to watch that study because it is in a database. The study hasn't started recruiting yet. But the interesting thing about this is that it is not a GW study, and the study is looking at several groups, looking at low and high, low THC, high CBD, high THC, low CBD, mixed group. And that's very interesting because this is not just Sativex. There have been a lot of attempts to look at multiple diseases. One of them is Huntington disease, and unfortunately here, despite a long-term work from 91, 2009, the most recent 2016, no improvement for that disease. So whether there are other anecdotal reports that I don't know, but nothing. For Tourette's symptom, there's been quite a lot of anecdotal report, and actually also improvements in the control of motor and vocal tics and obsessive compulsive behavior. And note very recent data published in May this year, a small study, but nevertheless good preliminary evidence on both effectiveness and tolerability of adults with that symptom. Parkinson's disease, there has been quite a lot of work, again mixed. There is a study, fairly old, showing absolutely no improvement, but note single episode. We all know that that would do absolutely nothing, so probably the wrong study. Again, in a very small study, but reduction of levodopa-induced dyskinesia, and yet another study, very short, again, nothing. But last year, a very nice review, and for those of you who will get the copy of it, I suggest reading it. It's quite long, but it looks at pros and cons of using cannabis in this disease. Glaucoma, again, very mixed data. A lot of people will tell you that there has been an effect, but actually not very much. And this data goes from 2004, 2006. And again, very nice review from March this year, looking at, from March last year, looking at how cannabinoids could be used. So what we're seeing here is a work in progress. Studies are difficult to design, they cost a lot of money, and they very often don't work if the design is not correct. Rheumatoid arthritis, again, fairly weak. There's some improvement, 2006. Some improvement reported in 2008. And my own countryman, Cochrane collaboration, essentially not so long ago stated is perfectly useless. Epilepsy, we all know that this is very, very attractive, that a lot of children in particular have been helped with epilepsy, and you actually see data as early as 2001. There is work looking at proposed mechanisms in 2010, and despite the fact that my colleagues in the UK consider it insufficient, I know from personal experience that there is a growing patient population in UK because the kids need it and parents are desperate. So this is happening despite the regulator, obviously. And you have a relatively recent data on cannabidiol. That is March 2016, quite a large study, and the study recruited over 200 patients, and notice that the reduction was only 36%. So the clinical studies, for whatever reason, do not report this total cessation of the symptoms that we see from other reports. And we have no reason to think that people who are reporting these are wrong. But note that, for example, for this study, the people were not taken off anti-epileptic drugs. So, of course, you're looking at cannabis as an adjunct, not as a only compound. There has been quite a lot of work done in psychosis and schizophrenia. Again, very little evidence, very small sample size. Alzheimer's. We've heard a lot about Alzheimer's, and you can see that as early as 1997, we are reporting positive changes in a disturbed behavior. And, you know, anyone who knows reduction in severity of agitation, and again, my colleagues in the UK say it's insufficient clinical evidence, but for anyone who has looked after Alzheimer patient, and I had 2 in the family, I can tell you however minor reduction in any of these symptoms without profound side effects of the drugs that we have currently on the market is a huge difference. You don't understand that until you have a patient at home. And we treat these patients with drugs that give them, for example, incontinence after a little time, which creates more trouble for the family than they had before, and so on. Anxiety and depression. So there is a fair amount of data, again, both for cannabis and THC, and you can see that the data actually does report improvement in depression, and it is as early as 2005. And there is a report of self-reported positive effect, both in HIV patients, and of course, improvements in anxiety and neuropathic pain. And of course, you have antagonist, which is synthetic, and actually we all know it was taken off the market because the was connected to significant incidents in suicide. And as somebody else talked about it earlier. And again, you have CBD with quite a lot of increasing data from 2004, as early as 1982. Again, these are all studies, but note that the positive effects have been reported even there. There was the study from 2004, and again 2009, and more recently, much more robust double-blind placebo-controlled study that actually showed a significant reduction in anxiety, cognitive impairment, and discomfort in patients who suffer social anxiety disorder. So the data is there, and a lot of it, actually. PTSD. There's been a big fight, and any American will know that the fight has been quite significant for the veterans who wanted to have this research and reimbursed and allowed through the normal channels, through the VA. And what you find here that on one of the studies, admittedly with Nabilon, so this is not really cannabis, but nevertheless, 72 patients actually reported either total cessation or lessening of severity of the nightmares. So if nothing else, it is very, very promising. And a new study from a colleague who couldn't come here is actually being conducted, and I do hope that these guys will get good data because I think they should get better data with the extract. That's again more later one with Nabilon with the synthetic cannabinoid, but nevertheless very promising. So for sure, cannabinoids are working, and as we've heard before, if they are used as a crude extract, probably the chances of working will be even better. Interesting idea that many people have had to use cannabis to reduce symptoms for those who are coming off harder drugs. There is one study here, 2015, that actually doesn't confirm it, but it's only one, and I'm pretty sure there will be others. This is an interesting study, although rather boring, but actually it shows very nicely how THC can be used in older patients with dementia, and of course, in the light of the results that are coming for people with dementia and Alzheimer's, that's also very positive and useful in terms of adjusting the doses in the future and so on. Cancer treatment, we all have heard about cancer. This was a very small study conducted by Guzman in Spain. It was quite a extraordinary study because the THC was administered into the brain intratumorally. So anyone who understands that needs to have a vision how that is done. You have to make a little hole in the skull and deliver the drug to the tumor. But nevertheless, there was a increase in length of survival, and even on that, in that extraordinary administration, there was some evidence of clear efficacy, and it was a very, very small study. There is another study that has been published relatively recently. This one added THC and CBD in patients with glioblastoma, and there is statistically different survival for these patients. And this is a GW study. They have now orphan drug registration designation for both US and European regulators for this indication. So what's the future? Most people don't know it, but I spent a good portion of my life early on researching traditional medicine in both Africa and Latin America. And to me, the cannabis community is somewhat similar. And please don't get offended, but I've really enjoyed working with traditional healers. I have publications and compounds and development to show for this. And I think we are with cannabis where we used to be before. Essentially, the two communities are mainly the traditional one, i.e. the physicians and the regulators, very often don't want to know. Because I think that there is a lot to be learned from the anecdotal experience, from people that have grown the plant, that have used it, from patients who have had a very clear benefit from it. And there is something to be learned from the way it is done through the normal regulatory path. Because I can tell you, when you assume that the regulator won't allow you to do it, that's complete nonsense actually, because the regulator has to do it. The regulator will allow you to do the studies. And the difference between saying I have seen patients recovering versus providing the evidence is that when you're sick, you go first line. Most studies here, notice, are second, third, fourth line. So in most countries of the world, when you have cancer, even in those places where it is allowed, you will not get it first line. You will get it fourth, third, fifth. And we know with cancer, early detection, early intervention really matters. So I think it's important to at least look to whether there can be any collaboration. One thing I want to point out in completely different walks of life, National Cancer Institute screening success for new active compound is actually dramatically greater when the traditional medicine information is taken into account. And we are ignoring that in cannabis. And we have it. We have it because we have people that have done it for many, many years. But at the same time, this knowledge is growing. And I think what we're actually also suffering from is the fact that, that certainly happened to me. When I did my PhD, I went to the library. Today, books that I have read are not found on the internet. They just lost to majority of young people. So in fact, we are rediscovering what has been published in 30s and 40s. Some of us who have the privilege of misfortune of being a little old still remember it. Those of you who are very young and going forward just may stumble across it if you wish to go to the library, or you don't, or you embark on a rediscovery. I think that's worth remembering when you work on cannabis. I think it is useful to look at the old knowledge and the new knowledge together and see what we can do. And the other one, what is next? What makes sense? Should we legalize everywhere, and should patients grow plants for their own use? And will they do it well? Will they have good, healthy plants? Will they use it as self-therapy? Do they need any expertise from anybody to help them to know? Do we need more evidence? Also strains, clones, seeds. This is, for most people who are not involved in this society, a big enigma. People want to get extracts, but which extracts? Where from? How good? How well assayed? Are they moldy? Are they free of bacteria? And how do we fund it? One thing that I would say is clear, that medicine is not free. Medical systems are not free. I've worked for many, many years on AIDS in emerging markets and developing countries, and even when the drugs got very dramatically reduced in terms of pricing, one of the major things we had faced wasn't the price of the drug or the price of delivery of the drug to the patient. It's actually the price of medical service, to be able to look at the data, to diagnose them, and to monitor them. So I think, with people that are here in the audience and will be here tomorrow, this is something that is really worth discussing. Is there any bridges that we can meet? What are the best way forward? And obviously they are different geographically, but ideally one would like to see that integrated into the health service. Why not? Why can't we have a proper diagnosis of cancer, and why can't we be offered a properly standardized, good quality extract? Doesn't matter who makes it, as long as it is actually there and we can save lives. Thanks very much.